Okay, so what is meal support? Meal support for you, as a person doing meal support, is a set of strategies that helps to minimize the anxiety. We're trying to use the structure and the support as a consistency tool to help them know the expectations, understand what's going to happen, be a part of that care plan, and then use that care plan if every meal is presented and provided the same way, where they understand what's in front of them. Sorry, I'm going to move a little bit quickly. We're going to go through some some strategies that you can do both before, during, and after as well. So we'll just fast forward. The number one thing I'd like to reiterate is the collaboration and compassion. So we've obviously talked a lot about emotions today, as well as the collaboration and the sense of control and choice. So when you can say, we're going to get through this, I'm not saying you have to offer them a choice that says, do you want to eat breakfast or not? That's not a choice that we're going to give them, that you're going to offer. That's obviously something that might get presented to you. But obviously it's ways of, well, what on the plate would you like to eat first? Sometimes starting with that safer food, right? They might feel a little bit more in control. Like that's something that they're always pretty good with their vegetables because they like their no-calorie food, or proteins are a really safe food that starches aren't. So I'm going to start here. That's a small win that you've offered them some control. You're letting them have choice, and not that I think anyone here is going to say you must eat your sandwich before your soup or your. But if they're having a hard time, that's one way of framing it to provide them a safer place for them to start. Because then once they have that success, they can build off of that. Okay. So the support before the meals, the dietitian's job is to try to identify what have they been eating before. We've talked a lot about refeeding risk today. So if they're eating 300 calories versus 1,500 calories when they come in, obviously that's a big difference on where I can start them at. So trying to identify what's been working, what their fear foods, what their history is on nutrition and their eating habits. And then try to create a collaborative plan with choice with them under the umbrella of why they're here and how we have to move forward. The care staff, some strategies that you can be doing is things like encouraging use of the washroom beforehand. It's hard when we say when you really can't go to the bathroom for an hour afterward, but we kept them so busy that they haven't had a chance to just go pee. And then now they're feeling uncomfortable, they're feeling bloated from the food, their bladder's growing. We're not creating a very comfortable environment for them. Distraction meals, so we know that that's obviously going to be a time that they're going to be building in anxiety, so try and keep them distracted. A little conversation, if they're allowed movement, maybe let's go to it's really nice day, why don't we go to the window for a while? They might not even realize that by the time they come back, lunch is going to be here. And then also looking at what's been happening for them. So are they really at a point where they're having a lot of GI dysmotility, and we want to try and offer them some medications because that's been beneficial on past meals, and they've been able to keep the meal down. Does it work better if we have your ondansetron before you eat? Is that helping you? Or an anti-anxiety medication, asking those things, and then trying to keep that as a part of the care plan so that the next person knows in advance this has been working well. You can still offer them choice. Is this a meal that you'd like to have something before we get started? Just really quickly, when we create a care plan, we try to make sure that it's outlined. It always is a little bit dicey depending on what time a person comes in, so obviously a little bit of grace period, but we try to have a very clear meal plan that food services get, and a copy goes onto the chart so that whoever is looking after the patient at the bedside it can be a carried LPN, RN, PCC, whoever can go through when the meal tray is shown up to make sure that it's accurate. Different approaches for refeeding. This is a little bit looking at where is a person at. If they've been refusing any solid food, so in our example that Dr. Libby gave, the 15-year-old was admitted to 5 South for an NG. If you have not been eating anything, that slow trickle of food might be an easier thing for you to handle. So we look at kind of where's the starting point? Obviously the goal is that by the time everyone leaves, they can eat a meal plan that's consistently a solid food. Sometimes nutritionally they need enough calories that we still have supplementation of a nutritional supplement like Ensure Plus. But sometimes people come in and they don't eat an NG, they're willing to do it, but their stomach is the size of a walnut because they haven't eaten anything for months. And something like drinking Ensure is actually a good step forward for them. So we will assess that and make a plan. Again, like one of the reasons why you might see patients have very different care plans. If there is no dietitian on, they come in on a weekend. I just wanted to make sure everyone's aware. So the standard refeeding diet A is what it's called on the PPO. So a physician comes in and ticks that on the pre-printed order. You have that as a new diet order that you can order, and then you can find this on the eating disorder toolkit. You can print this out so that just because I haven't written out exactly what they're going to get, this is a standard that's going to come. Obviously, there's some things that are a little bit vague. You know, it might be a vegetable or a fruit serving. It's not specific, but you guys can interpret that, so it's not a big deal. So just know where to find that. Yes?
Just in that case, if they come in on the weekend like that, like you said, like it's not always so rigid. Like if someone has a small stomach or something, can we then make those decisions? Like they're not tolerating real food, they need to start with liquid, or how does that work on a weekend?
That would be a team conversation with the physician as to how that's going to be handled. The physician can still identify that perhaps feeding tube might be a better option. So I'd present the information back to the PCC, the physician, and yourself to have that conversation about what you've seen as an issue. Sometimes we let someone have the first couple days where we don't necessarily initiate anything until everyone's had a chance to interview and figure out how we're going to be collaborative and get them participating. It's always offered, which is why the planned admissions that Nadine talked about is 100% the way to go. Good documentation so that we come in on Monday, we know exactly what's been happening and kind of where we need to go from there. Okay, jump in, Nadine. Sorry, we're running.
So with this slide, the kind of the most important thing is that with meals, they're accurate. So when food service brings the meal up, they should give it directly to the nurse or the carer for that patient and bring out the food plan that Mandy has provided to you guys and check the tray versus that. If anything is different, it can be fixed right then or there. But know that, yeah, sometimes due to food service constraints, there is going to be a substitution. But you go into the patient knowing that, explaining that to them. If they don't want to have that, they can have the ensure instead, because they might not want to have an egg salad sandwich instead of a ham or something like that.
So if they, everything on the tray is okay, but like the apple, so they don't eat the apple, or then they having to drink the ensure because they didn't complete the whole meal? Or would you just be like, okay, it was just the apple?
So the ensure replacement is actually based on percentages of the tray. It's from 0 to 49 to 50 to 100. So an apple wouldn't be the whole tray, so they would have to do the 125 mils of a nutritional supplement.
Cool. And so part of, accuracy and consistency at meals is kind of checking, well, what is the meal replacement right now, and being aware of things like that before going in, because it will change as their calorie amounts go up through their admission. We want to take anything off the tray that has numbers or that can help them kind of keep track of what they've been eating and kind of feed those eating disorder thoughts. And not having the ensure bottle on the tray. We also, don't want to have access to outside foods or the patient kitchen, just because that provides opportunities to engage in eating disorder behaviors. So just that reminder that checking the plan of care before you go in with the patient. So this approach that we've been talking about, like I said, is not just around meals, it's at any time. So just knowing that what you bring to the moment, just be like calm and confident that it's just your presence, you being there, that will make the difference. You don't have to say the right thing. You checked the plan of care, you know what's going on, and so just be confident in that. Having a consistent approach really makes meals and the entire day just way easier. And really having empathy and compassion that this meal is going to be difficult and that you're there with them through it. So modeling during meals is really, really key. A lot of people with eating disorders isolate, so don't eat with others. We're trying to teach them just normalized eating, and part of that is being social and eating with others. So that's why it's really key if the person doing meal support eats with them. We provide a food service tray. If you have any like allergies or anything, you can order a special tray beforehand. And having very similar food to them is kind of the best option. If you would rather have your own meal, just make sure that it's a balanced meal, includes 3 or 4 of the food groups, that there's no diet foods, and just being aware that something like a salad and an almond milk, that's what their eating disorder wants them to eat, so watching you eat that can be pretty triggering for them. We also want to model just, our demeanor around meals, that we enjoy food, avoiding negative talk about ourselves or others in regards to body or weight, and also avoiding food talk in general, just because with eating disorders there can be that preoccupation with food in general, even sometimes positive conversations around food, and that can be what the meal is all about, and we just want to take some of that away and just have a bit of conversation about other things. So definitely expect that there will be resistance at times, and emotions will be high, and trying to avoid negotiating in the moment. So you know what the plan of care is, you know what their meal plan is, and anything that's brought up, you can bring back to the team, but just to avoid that negotiation in the moment. And if people are consistent with that, they'll know that it doesn't work for me to try to do this during meals. They may or may not finish their meal or meal replacement. Mandy will go into this a little bit more in depth. And just be aware of any eating disorder behaviors and kind of notice them in the moment. And you may or may not feel comfortable helping them through that or confronting them about that. And if you don't feel comfortable about something in the moment, you can just leave it and talk with the nurse or the PCC afterwards, or ourselves, and deal with that. And all these things are definitely related to increased anxiety and other emotions that they're experiencing. So like we said, ask the client what's helpful. Conversation may be really good, but asking too many questions and making them talk too much makes meals a little hard for them to finish in a half hour. And distraction, some people like word puzzles and games, or having the radio on, or an audiobook or something like that, but just finding out what is best for that client. And also, we don't want to stare, make them uncomfortable, that's not normalized eating, and makes it that much more difficult for them to eat, but just be aware and notice, and just try not to make them feel uncomfortable. We really want to avoid problematic conversations. So the first example here is kind of like a judgmental attitude, are you supposed to do that? You shouldn't be doing that. And just knowing that, if they're eating disorder, that is making them act out in this way, but having more of a validation approach. So it looks like you're having a really hard time not exercising. I understand that, you really want to be moving, you've just eaten, this is really difficult for you. Is there anything I can do to help? Just kind of going through those steps of EFT. Do you want to play a board game? Is there any distraction that would help in this moment? So avoiding that judgment and validating what they're going through and helping to problem solve. We also don't want to put the onus on them to implement their care plans. So if we ask them, are you supposed to do this, or are you missing something from your meal, their eating disorder is going to want to deceive you, and that's not a nice position for them to have to be in. So be the one to know the care plan and to implement it by, say, adding something to their meal. And we also don't want to threaten. So this is definitely something that has happened before. So if you don't eat anything, or if you don't eat what's on your plate, you're going to have an NG. So using that as a threat, or you keep going along this path, you're going to die. And they have enough fear, they have enough anxiety, and we don't want to add to that, and it's not motivating for them when we threaten them that way, right? It won't result in change. So instead, that same thing, validating, you're really scared of eating right now, I'm here with you, can you take this bite together? Any questions about any of that?
I have a quick question. So in the support person meal tray, so if we're eating breakfast with them, do we have to finish it? Because it is a lot of food, for
And if it's difficult, maybe bring in what you can eat and not bring in the whole tray.
Okay.
Just so, yeah, they're not seeing, oh, you're leaving like or like a few items.
You're
bring
one
in,
of the milks and
yeah.
2 of the sandwiches and
Yeah,
this is
we
a
have to
lot
walk
of
around
food.
all day after
It's
that.
a lot of food.
Well, you should, the meal support person is not supposed to get an identical tray, especially if someone is further along in their admission. They might be receiving 3,000 calories. It's not intentional that the support person is also eating that.
Okay.
And it's our job to be supporting and educating them why they might be eating more food at this point, but that even for them, they understand that it's temporary. As they've progressed in their illness and the recovery, they can pull back. So they understand that that's not normal meal portions,
Okay.
and that you're allowed to be eating less.
Okay.
So if you get sent the same thing and there's 2 sandwiches, you don't have to eat that. Have a regular balanced meal. But again, the bigger issue that we have is if you're leaving a bunch of things empty, or you come in with your own lunch and it is the almond drink and a salad, that's not necessarily a normalized eating pattern. But we want them to aim towards down the road either. So be cautious. Okay, so really quickly, so they haven't been able to finish. They haven't, you've gone through, you've had this supportive meal, everything's going well, but they're unable to consume that meal. What do you do? What do you do?
You can encourage them first.
Absolutely.
You do like what, just get through one bite at a time.
Again, all those things that we talked about this morning, right? So understanding what it's like for them. Their eating disorder part of their brain is telling them, every bite is making you fat. You know? They want to be strong. They're aiming towards recovery. They're trying to every bite, they're trying to get over that. They're trying to do that. But if they can't, what do you do? So this is where we pull out the meal replacement program. That's that Ensure. It often comes up as a bottle on their tray. It's designed to be pulled off. It's just so that you have a new fresh cold one every time, because otherwise you might not have word stock. So make sure that comes off the tray for a couple of reasons. Again, we don't want anything that has labels or calories on it. This isn't a failure, but sometimes it's easier to be drinking a liquid. So it's easier to have something that's a smaller volume. It's a little bit bang for our buck when we think about how to replete someone. So I might be standing here talking to your little frail old elderly, and we give them med pass, right? A small little liquid that they can get down. It's the same idea for them. So it's not that it's a failure, they haven't been able to be successful. This is to say, this is another choice. This is something else you could do. And it's not, if you don't eat this, I'm going to go get that Ensure. We call it a nutritional replacement. We just want to support them. And it's just to give them a different way. If this isn't working, maybe a liquid that we can just get a little bit down might be an easier way. And likewise, if they can't even do that and they require that NG tube, again, that's not a failure. That's just someone that requires a different strategy. Maybe this might be a better way to help you again with your goals of recovery. Okay, so sometimes it's a bit helpful to not think of it as stages or failures or negative. It's about what's going to work best for them. So again, if someone needs to come in and they're on a feeding tube for the first few weeks, who cares? That's fantastic. They're getting nutrition in their body. This is way better than where they were, so I'm thrilled. We'll get there. We'll get solid food in them. So remember that, and don't let them feel like it's a failure either. Okay. Make sure you pour it into a cup so that they don't know how much, or they're not counting those calories, because that's another thing that their eating disorder part of the brain wants to do. Whereas if this is a safe thing that you're providing them as a part of their care plan, and when I've created the care plan, I don't talk numbers. I say it's all about normalcy. There's sort of some food group portions that we're kind of creating into here, and so it's the same message that you can be using. This is just an amount that we need to replace what you couldn't get through, but this is part of the same care plan. Okay. If they still can't do that, obviously this fits a little bit more what you're saying on a weekend. This is where we need to come back to our team. We need to pull in more people. Perhaps a different person, perhaps a different nurse has had success with them. Maybe you haven't had time to build rapport, and whereas they've actually come off of a few really good days and that other nurse doesn't have them today, pull in your other team, pull in your PCC, pull in your social worker, the dietitian, the physician, because we all want to have the same message and we want to all be there as their supportive team. Sometimes patients will say to me, I don't want to do this, but every person that comes in beyond these curtains tells me the same message, so I feel like this is a safe plan. They actually buy in because everyone's told them the same message. So if they can't do it, it doesn't necessarily mean the meal has to be over. What else can we do to think outside the box to help them in achieving their goal, their plan? If we think of this as us telling them they have to get through their meal and they have to eat this food, this is our plan. This is their collaborative plan. We've only had one involuntary patient in the last many, many months. The rest have been voluntary, and we've seen some pretty scared individuals who probably didn't want to be there when they first got here. But by creating that collaborative plan and offering them choice at every single meal and helping them create their care plan, they were able to be successful. And many of them have actually gone on to either the program and been successful with these guys, and actually a number have gone down to tertiary sites now at St. Paul's, Looking Glass, BC Children's Hospital, where they're getting that really in-depth residential, so 24-hour care treatment towards recovery, because they chose that. We just helped every day support them towards their own goal, okay? Bring in the PCC, bring in your team, because even if no one else can do anything about it, we also need to be looking at how can we modify the plan or what can we be doing differently. Recognizing what a patient's going to need post-meal. So they were successful in getting there, and now they feel horrible. They feel horrible mentally, right? They've gone against the eating disorder part of their brain, all that coping strategies they've had that got them this far. They've gone against that, eating 600 calories. They might feel physical symptoms because they haven't eaten a lot, so they often tend to have very poor peristalsis, and it's just sitting in their gut, they're bloated, they feel ill. So they don't feel good. They feel a lot of anxiety, a lot of guilt. So supporting them. So again, coming down to their emotional level, but then also distraction. And I have asked a lot of eating disorder patients what's going well or what's worked well with the nurses. And they'll say to me, distraction. Or my family came in, we were talking about different things. I didn't even realize an hour and a half went by. I digested all that food, I felt good. Yay, we did it, right? Each meal, we're just trying to get through each meal until we can kind of bridge to a better place where they've got all those neurons syncing and some good healthy behaviors so that we can work with them and get them successful, or get their weight up so that they've actually got enough nutrition that we can be successful with their working. So expect them to feel poor, expect them to want to exercise if that's their history, or purge, or even self-harm. So again, being really cognizant of that. So that post-meal hour is not just about making sure that they don't run to the bathroom. It's about everything else that's going on for them because they're feeling a lot of guilt. Support beyond the meal, and I just wanted to spend a minute on this because I think Nadine and I have spoken a lot about it, but one of the things that I see a lot of, and thank you, Sean, for bringing it up this morning, being so real about our own fears about being in the room, and we all just kind of do this, and that goes for everyone. So I say to a hospitalist, I need you to admit a patient, that's a psychiatrist's job, or they need to go to One South because they're a psych patient. Or they've got a one-to-one, so as the primary nurse, I don't need to go in that room. Or social worker, we're too busy, we can't go in there. Dietitian, scary as heck. We all do that, but the more and more team members that are in that room, I said it earlier, we're building that team of people. If we all have the same consistent message, they feel strength, that as they are making choice towards recovery, we're all giving them that same message. So one of the things I really wanted to push towards today is getting as many people feeling more confident and comfortable with this delicate topic and how tricky it can be. Because even if you're, the primary nurse is on break and your partner's got this patient, spend a few minutes, introduce yourself, right? Honor what they're going through, congratulate them, whatever's necessary in the moment. Just introduce them, just, hey, how's it going? At least you got a room with a window, it's sunny. Make a little connection, make a little bit of small talk, you're distracting, you're creating a rapport, you're making them feel welcome, and that's huge. So often, when you come on the unit and you see these people sitting by themselves, what are they doing? That eating disorder part of their brain is stewing, right? I ate 537 calories at breakfast, I know it because I count calories, and that's, oh my God, they're just doing this. Go in, distract them, be their friend. You don't have to spend long, but it's also gonna help to bridge and create your own confidence with the patient type. And you'll be excited. And then you can come back and say, this is a new challenge and I love this patient type, because that's what we're trying to do. So 4 North, 1 South, 5 South, we have a unique population that can come visit us. the whole point of doing all this work is to do a really good job with these patients so that we can have these continued success stories, and it comes down to the people.
Is it okay to, like, post-meal, like, how are you feeling right now? With that, because I don't want to, again, it all comes down to making them cry, like, trigger anything where it triggers the anxiety by asking them how they feel. You know, am I going to trigger that spinning if you ask them how they feel? Like, I'm not seeing any sadness, you know, we're just hanging out and they've gotten through their meal. Would it be appropriate to ask, like, okay, so you got through the meal, how are you feeling about that?
One thing we say about emotions is that you can't plant something that isn't already there. So if they're feeling fine, you're not necessarily gonna, make them all of a sudden feel sad or really anxious. If there is a little bit of underlying, then maybe, oh yeah, it's there, well then, we'll do something about it. But you're not, like, asking that question isn't gonna put you in a worse situation, and you're not gonna plant something in them that isn't already there.
Some of these people are so good at covering up their feelings.
That you don't know.
You don't know, but you're inviting them, that you're saying, I want to experience this, I want to walk with you through this. So you're inviting them to share that with you. That's creating rapport. That's walking with them. So then you go back to all those steps that you learned this morning after they've shared it, because now you have the information, so you can validate, you can work with them to help invite them for you to be on their journey with them. You'll learn some really cool things. Because I think that's the piece that for me, I'm very similar. I don't come from the psychiatric background. Like, I love when you guys walk in and you're like, yeah, this is awesome. That's not where I started, right? It's like, what do we do? But the more and more you hear those things, because you've actually taken the time to interview and actually hear what's happening for different, and everyone's different. Every single one of the eating disorder patients with eating disorders that I've worked with has told me something different when I've asked that question. So that's helpful to understand the realm of the possibilities and then kind of dig in a little further. But by taking that few minutes to ask that question, they feel validated that there's a person there that cares and wants to understand and know. So I give you credit just by starting there.
Okay.
Yeah. Any other questions?